So first of all, I really want to welcome you to the Novel Idea Society for your book this month, The Last
Aha,
Doctor.
yes, yes, okay.
I will admit, I am not one that goes into nonfiction medical books
Okay.
for pleasured reading, but I will say I am so glad that I picked this up, and I'm so glad that this book was pitched to me from your publicist, because I think that this should be, in the world we live in right now, required reading.
Yeah. A few years back, I said that of Atul Gawande's book, Being Mortal. I said that is a book that should sit on your kitchen table right beside your Metamucil, because it really did deal with the humanity of medicine, from an author who, at the various highest levels of being an oncologist at Dana-Farber, really kind of understood in the end what it was to kind of provide care for his parents, and sort of where it fell apart. And the person who stepped in and was the best help for his frail father at that point, was in fact a visiting nurse who really understood what was required and needed at the end of life care for his father, who was a preeminent nephrologist, and who happened to have, an oncologist for a son. And between the two of them, they couldn't figure it out. But a visiting nurse did. So he tells that story wonderfully in the book about, what it is to be kind of a caring, end of life practitioner. And it was something that he, in fact, was not familiar with, when he set out. So I always thought that that book really brings it home in terms of what is the journey that everyone must make when they come to kind of end of life care, when they especially come as sons and daughters of parents, because that's where you always begin, when you're sort of dealing with aging parents and frail elders. You are their son or their daughter, for the most part, when you're trying to source and figure out and provide the care that they need. So that's a long way around saying, yep, I think it's a good primer. The Last Doctor is a good primer around a very specific topic, for assisted dying. But very, very few people in the end really request an assisted death, like 5 to 6% maybe. That's been the practice we have seen over the last 20 years. That leaves 95% of the population who have got a lot of issues around end of life that have to be dealt with. And they're mostly dealt with by their children, of course.
Are you still practicing as a doctor?
Oh, yes. Yes. No, yes, yes. I stopped doing what I was doing because I was doing a very active family practice and obstetrical, service, uh, 2 days a week and 1 weekend a month. And when the legislation passed, when the Supreme Court passed their legislation in 2015, I stopped doing obstetrical care, spent a year on kind of, an independent learning program on end of life care, as it is practiced in hospital clinics, oncology clinics, small community hospitals, hospice units, and the community of MAID providers at that point. So that was a year and a bit, while we waited for the legislation to come into effect on July 2016. So I have been actively involved in MAID assessments and provision since that time. And I'm out of
So,
Toronto. So I work in the community in Toronto,
yeah.
although I'm kind of in and out of long-term care homes and in and out of hospitals and in and out of palliative care units. So I get around.
It was funny when I shared that I'd finished this book. Someone responded on social media to say, "Fun fact, Dr. Jean delivered my first daughter." And you must get that, like, that cradle to grave care.
Yeah.
When you went to medical school, is that
Mhm.
something that you knew you were going to want to do then, or is that something that evolved through your career?
Um, I came into medicine from nursing,
Hmm.
so I knew about care. Um, and I actually, because I was doing visiting nursing before I went back into medicine, I actually knew what it took to do home visitation. And I actually knew some of the issues and difficulties that arise when you are trying to provide care virtually at every level of of wealth or poverty, of good care and really cobbled care. So I went into medicine with a fairly good background in what it was to attend to the care needs of patients. So when I finished, and I was old going in, so when I finished medical school, it was really not possible to sort of carry on doing specialty medicine. I came into medicine out of psychiatry. So the easiest thing for me would have been to stay and do a psychiatric residency and then become a psychiatrist, because that was the easy part. What was not easy was to step away and open my office below the kitchen, having had the second baby. So there was a big juggle, like right from the get-go. But it was kind of like, you've had enough schooling, now you must practice. So I came into it knowing that it was time to go to work. I loved being a student. I don't think there's any better occupation anyone can ever have than being a student. And since I kind of semi-retired, I realized I now have got much more time to do CME than I've had in 45 years. I love it. It's like I love going back to school virtually in any way I can. So and in fact, the MAID curriculum, which has evolved over the last year across Canada, is something like 180 hours of CME to kind of do this program. And it's a really excellent program. So it unifies the whole of Canada, right across Canada, in terms of assessors and providers, in terms of the standard and practice of care and provision of this service. So yeah, learning forever is what I kind of call it now. And it's wonderful. Okay, I'm no sound.
Yes, but it is fixed here. So that is
Oh,
why
good.
I am.
Okay.
And we can turn it up and lovely. Okay. We're good.
So
Everyone got real
did you
close
get
to me
that?
for a second there. Yeah. Okay, we're good. Now they can hear you. It was very crackly, but we're fixed. Thank you for
Okay.
helping us. Um, so education and lifelong learning, as a journalist, I totally get it.
Yeah.
That desire to learn more, because you never really know, like, life evolves so much, people evolve so much, science evolves so much. And I know you touch on this in the book, but what was it that drew you to medical assistance in death? Like, what was it? Was there a certain case? Was there a certain person? Was it a conversation you had with someone? How did you know you were
No, it
going to
was
start
45
leaning
years.
that way?
It was 45 years of medical practice. It was seeing people from cradle to grave, but my practice aged with me. And so the older you get, and certainly, in the critical years when you begin to see more cancer diagnosis, as opposed to the end of either your years when your aging practice is aging out with you. It was kind of knowing that we could not service people who had the greatest suffering, because it was a criminal act to help them die. And I have a downtown urban practice in Toronto. So, it was basically, a very highly educated population, mostly university graduates, captains of industry, people in the know, healthcare workers, very cognizant, very aware of what the legal system could and could not do around end-of-life care. And people who wanted autonomy, people who wanted to have mastery over the end of their life, people who were suffering, were really stepping away. And I knew it. I could see it in the practice when people said goodbye. And that was it. Because to say more than that was to compromise both them and myself. So I've known forever. I just didn't think I would see it in my lifetime. I was absolutely poleaxed. You people in Regina will know that word. I was poleaxed when I saw that 9-0 ruling from the Supreme Court of Canada that medical assistance in dying had to be decriminalized. And that was basically removing those two criminal codes, one of the practitioner who provided and the other of the family members who aided and abetted, because everyone was affected. And so families did it in secret, or people did it on their own, and didn't involve family members, just because of the implications with the criminal code. So it was something that I thought I would never see remediated in my lifetime. I was gobsmacked and overwhelmed, and I knew immediately what I was going to be doing, like that.
Take me back to that day that it was legalized. What
Mhm.
did you do that day? What went through, like, who did you call? What was that day like for you? Because you're
Oh,
not
it was
selling the
no, it was
ability to
7 in the morning. It was
adapt.
7 o'clock in the morning. I was leaving the gym because I was, this was in the spring. I was perpetually always training for Boston at that point. So I would run to the gym and I would do spin biking until 7 o'clock, and then I would race to the office. And I was leaving the gym, and it was just like, scrolling across the bottom, Supreme Court 9-0 ruling, for medical assistance. And I was staggered. I thought, I know what I have to do. It was instant for me. I knew I would give up the obstetrical part. I knew I would have to fashion a whole program of upgrading myself. Because I think when I approached Jeffrey Myers, the palliative care head at Sunnybrook, he said, "Oh, family doctors know how to do palliative care." I said, "No, they don't.
Mm.
It's been turned over." And the college, I mean, the College of Family Practice had by that time initiated a 9-month course of residents to continue on doing palliative care, but they were centered basically in the hospital system. And it basically was a technology that was rapidly evolving in terms of symptom management. But I can tell you absolutely, family doctors were not doing palliative care at that point. The clinics were doing palliative care.
Yeah, yeah.
The oncology clinics were doing palliative care. Congestive heart failure clinics were not doing palliative care. They still aren't, um, and certainly in terms of kind of gerontology and geriatric care, no, it was pretty abysmal in terms of sort of saying, are you doing, really good end of life care for your practice population? Because they didn't have a practice population. They were doing referral medicine at that point. So I don't think any, certainly not me, at that point had a really good handle on what was really excellent end of life care. And I included palliative care in that. I included hospice care. I included community care. I included small community hospitals because I think they did it best at that point.
Why do you think we're so uncomfortable with death? And I say
Oh,
that as
yeah,
someone
yeah.
who doesn't have, I still don't have, I still don't have my paperwork in order. Like, they call it the living will, all of those. And I know I've had these conversations. I know I should get it done. Um, but I'm not uncomfortable with the death side of things. It's just, it hasn't been on my priority list, and it probably should be higher. But why are we so uncomfortable with having conversations about dying and death and taking that burden off our families?
Well, I think there are a couple of issues in play here. One is the advance of medical science. But I think from the minute we turned care of our family members over to hospitalists, and this didn't happen like in the 50s. This happened in the early 1900s, when basically hospital institutions and kind of the practice of medicine became a specialty, and it stopped being sort of local. It stopped being family based. It stopped being the expectation that you will look after your elders because you kind of all live in the same home or the same community. So we had a dissolution of, family units. We had an institutionalized set of kind of care that evolved into more and more subspecialties within a hospital-based kind of care. We are a tremendously youth-oriented culture, no matter what. But I think we also have kind of lost a lot of family connection with kind of family members, drifting across the country for jobs, and sort of, that kind of dissolution of the family factor. But I also think we are incredibly focused on, specialized care in medicine and advances in medical technology. So I think the whole of this country, and this is certainly what COVID pointed out in the first year, that kind of dramatic 30-year dissolution of any kind of resource into community-based long-term care homes. So, you know, we kind of have ignored it for 30 years. Comes COVID, and 90% of the people who die in the first 6 months are people in long-term care homes and the elderly. So, I mean, so we live in that shame, you know, we live in the disgrace of neglect, and kind of bear the burden now, the responsibility of really not adequate attention or care or devotion, into what does it really take to provide proper end-of-life care for elders who increasingly will need more and more and more care and more resource, human resource. We don't have the manpower, we don't have the money. We've actually, you know, chosen 30 years ago or 40 years ago where to put our money. And it's been all in a hospital-based and advancing medical research and kind of offering an approach to life that sort of says, and by the way, we aren't ever really going to talk about dying, because we'll only talk about the next best thing we can offer you to keep you going. And we bought it, you know, we bought that vision, much to the sort of neglect and disregard for what it is to kind of look after elders, care for elders, respect elders. And we're kind of coming around to it slowly, but I can honestly say if it weren't for our indigenous communities, we would be still not paying any attention to elders or elder care. I think they've kind of, you know, forced us to kind of turn around and look at, do we actually have enough respect and regard for our elders and our elder care population to really pay attention and to provide them the care they need? That's a long answer for why we
No,
don't like to talk about death, you know?
I think it's one of those, I'm look at this as like positive or negative. I've had a lot of death in my life. I've been to a lot more funerals than most people I know. Like I've just was exposed to death from a very young age. And I think when you talk about palliative care, I think of my grandmother, and this might upset my family members, right, wrong, or indifferent. But I think of I remember she had cancer and she was diabetic and she had this whole host of health issues. And she went into palliative care and they took her off all the medication and she lived for months, like months and months and months and months. And this was supposed to be end of life care. That's what you go into palliative care for. And for her, it was hard because this was not end of life in 2 weeks.
Yeah.
We got to spend a lot more time with her as a family, but it was also very drawn out. And I don't know that if given the option, she would have necessarily taken MAID, but it was such a weird experience to go into what was a long-term care home, into palliative care, into this beautiful room. The staff was great, but it was reading this book, I thought a lot about not necessarily her, but just that experience, because I know she's probably not alone in that experience, where in some cases palliative care, you go in and you're gone in 2 days.
Well, the average is 10 days.
And I don't mean to be crass about it, because I know that these are family members and these are
Yeah.
people, but again, I've been exposed to a lot of death. So for me, I can talk about it pretty pragmatically in that
Yep.
way. But what have you learned about end of life care since you started providing MAID, since you started having these conversations with palliative care? How has your approach changed? I'm sure it's changed dramatically since the first one, but what is the biggest thing that you've learned over this time?
Well, I've learned a lot. But one of the striking things that I have learned, is about vigil. I have an enormous respect for vigil now. I get called in, to kind of basically provide a death for somebody who I think is actually having really good palliative care, in the home. But because they have requested or asked for MAID, and they're declining quickly, I get called in to provide. And I have gone into a number of homes now where the person is really failing very quickly. I mean, very quickly, like in front of my eye, they're kind of in and out of consciousness. And this is very hard on a family, especially if it's a sudden decline. But I have been in a few situations and circumstances when I have thought to myself, the palliative care here is excellent. This person is not suffering, they're actively dying. They don't need me. But because I have been called in, I get pushed into this role of providing for, the dignified death that the person requested. And I now know that, in fact, what is probably more appropriate is to say what this person needs is the family to keep vigil, the family to be there to watch, because I can see that this person is actively dying. And doctors are really bad. I think we're really bad at sort of saying the end is close.
Because it upsets people. You don't want to upset people in an
Exactly.
already intense situation.
Exactly. But we've lost the fine art of being able to keep vigil, and to know that the job you have to do there is to be patient, to witness this passing, to witness that this is an end of life that actually is dignified, that actually is not fraught with suffering. It's different if somebody is in pain. It's different if somebody is delirious and basically is kind of really out of it. But when you see somebody who is actively dying and the family is there and upset, and you go in and you just, you kind of, as we say, do an end run. I'm not so sure that is the best value of what end of life care can be or should be or ought to be for a family. But it does take a nuanced approach. And most of the time when I go in, I don't know the family. I don't know who's arrived from out of town. I don't know who's been there and is exhausted. I don't know who's the family support. So you go in as an observer, and I can be terribly efficient. I can be, in and out, call the coroner and say, this is, what's happened. But I'm not so sure that services the family needs in that moment. It's and I certainly have sat with people while they died, knowing that they weren't there to say, yes, go ahead and do it. They were past that. And I had no place other than to sit with them while they died. So I've seen it from a number of angles, but I actually am not afraid of what I would call a death watch. I think there is, in fact, a great value for a lot of families to actually have a death watch, as long as there's enough support for them while they do it. And the support comes not from me as an external. The support comes from the family. The support comes from everybody being there for each other and for the dying relative. And if we were only better able to prepare families for that, and to kind of know that there are symptom management kits, there are things a family can do, there are things a family member can be trained to kind of step in and provide for their sort of mom or dad or husband or spouse, and that empowers them and actually gives the whole family control of that end to some degree. So that's one of the things that I have learned. I also learned that basically, if you're doing it well, the palliative teams in the hospital, the community care service people who are coming in to provide care, the family members, you actually create your own team around what this end of life should look like. And it really is very much a shared responsibility. If somebody is in hospital and they want to get out to get home, we work really hard with the palliative units to kind of get them home, get them ready, have the lines drawn in. We all kind of meet up in the home then, and we provide, what a family member wants in their home. But it always, at this point, assumes that they will say, yes, I want you to go ahead and start those drugs. So capacity to consent in the moment is still a very big issue.
Something you touched on in the book, and something I have talked about with quite a few people over the last few days as we lead up to this, is when you talked about how in some cases the medical system has failed someone, and this is the option that they feel that they are left with.
Mhm.
And the things you wrestle with as a medical professional providing services to people in life and death.
Mhm.
And in that moment, knowing that legally you can say yes, you can have a medically assisted death, but the discomfort of knowing if only someone had gotten to you sooner, if you'd had an MRI quicker, if someone would have caught it in your blood work, you wouldn't be in this situation. How common are those requests made to you where you're
Not
like,
often, not
oh, this
often.
is not good?
Not often. What is more, and certainly what gets kind of talked about in the book, is kind of the social failing, the social network failing. And there are a couple of factors in that. One is that we simply aren't good at doing, providing that kind of social safety network for people, especially with chronic illness and chronic pain states, and mental disorders are just going to be huge in this when it finally when it finally, hits the books, and it will, but it'll probably come through the courts again and not through legislation, because it's just it's such a political hot potato. I don't think anyone wants to touch it. So I think the Supreme Court will get in on that again, because you can't just silo people because they've got a mental disorder. You can't say they're not capable people of determining their destinies because of a mental disorder. You can't say a mental disorder is not an illness. It is. You can't say it's not advanced. It is, can be. So so basically, I think there are a number of factors that we can that we really fail and that we let people down. And one of the things that assessors and providers from the get-go have wrestled with is, what is our responsibility? We may say, this person isn't eligible because the problem that they are presenting is not an advanced disease, illness, or disability. It is that they lack social housing, that they have no social network, that they've been isolated for too long, they don't have any more resource connections in their community or in their social ties. They have been abandoned, they're lonely, they're isolated, on and on and on you go. And it is a failure of society, and a neglect, and a kind of marginalization that we as a society do. And so we've wrestled with this from the get-go. Is it our job to kind of advocate, or is it our job to say, this is what needs to happen? You must now go back and talk to your doctor, your social worker, your case manager, the vet board, because you haven't reached out for services that vets are entitled to. We can go through that piece by piece. But in point of fact, what ends up happening, of course, is that of course we advocate. Of course we reach out and try and get the family doctor involved, or the pain clinic involved, or the local parish priest involved, or the pain doctor involved. And one of the great joys of doing this work is that I have been surprised more and more that when you actually reach out and ask for help with somebody about their patient or their client, or their parishioner, people respond. We're human beings, and we answer the call. We may not carry the call on our own hearts to kind of, wave the banner, but when you reach out and ask for help, I've always been really heartened at how people try and respond to try and help that person or that person's, glaring social deficit. And it certainly means that some of these cases become really protracted and involved, and you don't find the quick answer. I've carried people for years, year and a half, 2 years, as we try and sort through what resources they can still access. And I don't see any difference once mental disorders come. I don't see any difference in that job or that task of kind of making sure that, everything that has been offered, that can be offered, has been offered. It still rests with the patient to say, I don't want any of it. And I choose this exit for myself because I'm entitled, because I have met the eligibility criteria, because I am suffering. And it's not for me to ever say that somebody isn't suffering. We actually are remarkable in Canada for this very reason, because in some of the jurisdictions, like in Holland, especially around mental disorders, it is a joint decision between the practitioner and the patient if they are suffering.
Oh.
Yeah. So in Canada, we don't do that. In Canada, if you say, I am suffering, I have grievous and irremediable suffering, it's accepted. I don't challenge that. I don't say, no, it's not enough, So
I think it takes a lot for a person to admit that they're suffering.
oh yeah. Oh, yeah. Oh, yeah. And if you put it to people, you say, is this suffering? And you'll, especially older people, the 90-year
It's the
olds,
pride thing, right?
they'll say, well, suffering? I'm not suffering. I'm just at the end. I've had it. It's at the end. I'm at the end. I want out. I want to go. I want release. And you say, well, is that suffering? And they hate the word, They hate
It's
the
a
word
pride
because,
thing. There's something
yeah,
about
yeah, yeah.
suffering that we don't like.
We don't like, no, people say, no, suffering is, I lost my arm, I'm bleeding, I've got gangrene in my leg, I have, intractable cancer. But if you just say, is it suffering? Is it moral suffering? Is it existential suffering? Is it end of life suffering that you want release from? These are very nuanced conversations I have with elderly people. And I love it because the stories are there, the tales to be told are all there with our elders.
So you touched on this in the beginning. I think you said 5 to 6% of deaths are
Made.
medically assisted.
Mhm.
How many, what's the ratio of people who ask for it to the number of people you say no to?
It's not many. Again, because now that we've been doing this for 7 years, people are very familiar. I mean, I don't run across anybody now who doesn't know somebody who's accessed MAID, and almost everybody I talk to now who have had that experience have an opinion about it, and have an opinion about the dignity of it. They have an opinion that this is in fact a good thing that has happened for somebody in their family or somebody who they know who has chosen this. So part of it is they made the choice. Part of it is they deserve it. They were suffering. So I think people now who say, I have an aunt, I have a mother, I have a father, and here's what we are observing, and here's what we see, and we know that what their wishes are. So people now have familiarity with who asks and why. So it's very rare now. I mean, I think in the first 2 years, I would go to sort of places in small towns, and people didn't even know we had the legislation. They didn't know there was an eligibility criteria. But now people have a much more nuanced, appreciation of what's required and what's available. And they may not know that you need 2 independent assessors to assess your eligibility criteria, but we do that on intake, or I do that on the first phone call. And I will tell people whether it looks like they're in the zone or not. And if they're not, we don't put anybody through this process of sort of saying, hello, we've assessed you and you're not eligible. So I would say very few people now are assessed and found ineligible.
Do you remember that? I know you talked about rehearsing and going through the steps of what you were going to do on your very first provision, as you call it. Do you still remember that day really
Oh my
vividly?
God, yes. Yeah, of course I do.
You nervous?
Well, I was a physician. Physicians are not allowed to be nervous when you're
Well, yes,
when
you
you're
are. You're just not allowed to admit you're nervous to the people you're dealing with. You can
not
admit it
only
to the other
you,
people.
you don't admit it, you don't show it, you don't live it, you kind of get in and do the job. And when you've done the job, um, it's done. So it took me a long while to understand the impact. It took me a long while to understand what I call the burden of care. And I've been in the game for a long time. So I said, hey, my shoulders are heavy. I can carry a real load here. Um, I wasn't being fair to myself for sure. I thought if I don't sleep at night because I'm worried about this, I thought I'm on the right track. If I have moral dilemmas, then I know I'm on the right track. You should have some moral dilemma. My problem was I just held it all in. I wasn't putting it out there. I wasn't talking about it. I wasn't sharing it. Um, I didn't want to burden anybody else. It was a bit selfish on this, to not own that you have doubts about taking a life or what a life is worth or whether this is enough suffering. As I say, we never question the suffering that a patient is talking about, but doesn't mean we don't feel it ourselves,
Mhm.
is this warranted? Is this act of taking a life warranted because you're the one who's going to be taking it? So
How do you deal with the tough stuff? Like, do you have a good therapist?
that's what people said, who are you talking to? I said, what do you mean, who am I talking to? Why would I be talking to anybody about this? So yeah, I talk about it broadly now. And in fact, one of the things that I've had to learn to do is listen to what other people say about it as well. So it's not a selfish thing anymore for me. There was a bit of pridefulness in here about I can do it.
I can do it. I got this.
I got this.
I
Yeah,
don't need help.
exactly. It's water off my back, No, it isn't. No, it isn't. So, I mean, I have sources now. I look to poetry. I look to big thinkers. I look to the deep thinkers. I look to the Atul Gawandes, and I look to people who, in fact, have experienced trauma and PTSD and have had to relearn how to live. I kind of look now at how other people carry the kind of burden, and I actually talk about it now. I don't think before I wrote this book, and in the course of writing this book, when I had to talk about it, um, because I wouldn't have otherwise, I mean, boy, when I started this, you would have never heard from me about any of it, right? Because doctors don't do that, doctors don't have to do that. Doctors kind of hold it all in and just do the job and do the job excellently,
Mhm.
because that's what's required and expected of you. So now I cry. I mean, I'll cry with people now. Oh my God. It'd have been shameful for me to cry. I mean, for Joe, my very first patient, it wasn't when his niece came up and hugged me and asked me how I was, I almost broke down, but that was like unheard of, like somebody would show a little kindness or say a soft word to me and I could fall apart. Well, my goodness me, not tolerable. So yeah, I did a lot of running away from that kind of emotional connection. I don't do that
Literally
anymore.
and figuratively.
Yeah, pretty well. I was really efficient too. I could run fast. Yeah. Do the job and get out is really kind of what I was doing then. But yeah, so it's been it is a journey of learning for sure. But it's a marvelous journey.
How
It's a
did the book come
marvelous.
together? How did you end up with a book about, as someone who didn't want to talk about it, how
Mm.
did you end up with a book about it?
Oh, like pulling teeth, It was like, because this book was co-authored with Johanna Schneller.
Yes.
And I brought Johanna in around Yolanda. So Yolanda features big in this book. She threads the whole book. But when I was looking after Yolanda, I was really pushed to have her story told because she was talking about what was failing in providing me. And because she was such a qualitative, high-end researcher in the medical field at Dana-Farber, she knew her stuff.
Mm-hmm.
And she was critical of kind of where we were failing. And I thought, this is a public issue. This needs to be said. This needs to be put out there. And I couldn't do it. I mean, the privacy issues, and she was an incredibly private person. Like, she did not want her name anywhere. And I said, Yolanda, you have a story that needs to be heard. I can't tell it. Would you consider talking to a journalist? And at the time, I thought of it as a long piece. I thought of it as a kind of a 10,000 word essay
Like a
about,
feature.
yeah, like, this is what needs to happen. And she agreed, and she was really frail. I mean, so for Johanna, and I brought Johanna in because I knew Johanna, for Johanna to have 6 hours of taped interviews with Yolanda was huge, because Yolanda didn't have the energy to talk much more than an hour at a time,
Mm-hmm.
because of her shortness of breath and her oxygen needs. So, but they cooked it up, they cooked it up between the two of them. I didn't know that. But when I went to sort of service Yolanda, and I'm like, a foot away from her crystal clear blue eyes, and she looks at me and she says, "You will tell my story." I said, "Sure, sure. Of course I'm going to tell your story." I had no idea. But Johanna told me afterwards what the story was. She said, "It's a book, She wants this told in a book form." And then Johanna and I were to work out, well, what was the book to look like? And I picked the 8 patients, and they were all, and it was basically, I wanted to focus on the first year because I wanted to go from we knew nothing to
Mhm.
what have we learned. And then Johanna said, "Yeah, well, you can't do that without talking about you." I said, "Sure I can, because it's not about me. It's about these people, and these people really mattered to me." And this is like 5 years on. So we had to go back, and that was Johanna's job, to go back and interview all the family members, so we could have permission to tell the real story with the real name and not have to use pseudonyms and not have to, I didn't want any of their identities diluted in any way because
That's
I
really
needed,
special.
yeah, I needed to honor that. I said my relationship was, 2 hours, maybe 3 hours during the interviews. That was my relationship. But the family stories, the histories were large. I mean, they were huge stories. And so that was Johanna's job, to kind of go and round up these patient stories, and then distill out of that, well, what was the lesson? Or what was the magic here? Or what was the foundational truth that needed to be told here? Um, and then she still said, "But they have to know something about you." No, they don't. So that was the tug of war for literally 2 years. We wrote this during COVID, of course, but it was just like, oh God, what do you want me from me, And then I would send her what I written, and she would say, "But I need a little more. I need a little more," So that's kind of where we got. And still causes me pain and embarrassment, because this is just not what doctors do. Doctors don't do this.
But I think that there is a piece of you that has to acknowledge that you are engaged in a significant piece of Canadian history. Like, there are not a lot of doctors who so willingly jumped in with both feet and said, "How do we figure out, okay, we're going to do this?" There's even still to this day a lot of hesitation in medical providers. Forget the public. There's still a lot of questions and hesitation about MAID
Oh,
and
yeah, yeah,
how
yeah.
it works. So you have to give yourself a little bit of credit there. There's not a lot of you who were so willing to jump in and do this. And as a woman in the medical field, I think that's also really significant. So whether you'll give yourself credit or I'll do it for you, but I think that you do need
Okay.
to acknowledge that.
Well, I acknowledge it, and I also acknowledge that I kind of came into it with a misapprehension. I thought my job would be to show how to do it, show family docs how to do it. I will show you one, then I will accompany you with one, and then you will look after all your people. And much to my dismay through the years, what I have discovered, of course, is that that's not what doctors want to do. So across Canada, servicing 40 million population, we have 1,800 clinicians, providers, assessors, between doctors and nurses. And there are certain areas now in the country where nurses, in fact, provide 10% of the MAID provisions. So we are not a big number, and that we have a growing and aging population who are going to, in fact, come into this more and more and want control, especially around advanced requests for Alzheimer's. This is another huge area that's going to come to play. And there are not enough clinicians doing it. And around people who are going to lose cognitive capacity and want to have things in place so that it can proceed, that's going to be very difficult to bring into practice. So you're going to see more and more that it's the old docs who should and will probably want to do this and are able to do it. I think the young doctors are going to, by definition, shy away from it. I see that already, because I see too many doctors retiring, and the young physicians who are picking up these practice will just look at me and say, I don't know this patient well enough to do that. So my notion that family doctors would carry on this and would pick it up and do it has not come to fruition. In fact, they call me, they say, are you still in the game? Are you still doing this? And these are, these are clinicians who are kind of my age, maybe, 5, 10 years younger. If they haven't retired, they still don't want to do it for the people who they've looked after for 35 years. So it kind of shocks me. I look at that as duty of care. I look at that as the cradle to grave service that I kind of bought in the first place, So it's a bit of a shock to me to realize that not too many of my fellow physicians and colleagues have the same notion of duty of care that I do. And I'm saddened by that, because it sort of struck me from the get-go that this would be an automatic service that physicians would be proud and happy to do for their patients that they've looked after for years and years. So
If there's someone, I know we have medical people listening, watching, and this will live later on YouTube, so people will watch this in the replay. If there's someone who's working in the medical profession now and thinks, hey, maybe this is something I could do, where do you suggest that they start? I mean, obviously, if they're watching this, they're interested. If they've read your book, there's a notion there, but where does a person even start as a medical professional if you're interested in assisting in MAID?
Oh, you get in touch with the Canadian Association of Medical Assistants and Providers, CAMAP. So CAMAP is a nationwide organization, grassroots organization that got started right in 2016, 2017. We came together across Canada to support each other, to establish clinical practice guidelines, to basically kind of put in place recommendations.
That was almost like your little network, hey, when you were
It was
bouncing.
it was our online grassroots network, but now, of course, it's a national organization. And so they have basically evolved the MAID curriculum that basically the federal government required. It said we need much more education in this practice. So CAMAP basically spent the last 2 years putting together this 8-topic, procedural assessment, complex cases, medical disorders as the sole underlying cause, advanced request, all of these big issues, and have kind of over the time, I think it's evolved into about 180 clinical hours of online kind of seminars, and then facilitated sessions with each other. So it's an excellent program. I've done the program, and I didn't put it together. It was put together through Queen's University as their ongoing education. But that association, CAMAP association, is where everybody, whether you want to just provide or whether you want to just be an assessor, or whether you just want to kind of get familiar with where's the legislation at, what are the issues, that's the organization. So CAMAP, CAMAP. That'll get you sort of, right into the thick of things.
Okay, we have a lot of people logged on online. Normally I have a room full of people and very few people online, but we have a lot of people online and fewer people in the room tonight. If you have a question for Dr. Marmoreo, just put up your hand, because there's more of you than I'm used to, and you can ask your question if you like. I'm sure there's a question or a comment on the book or anything she said. But if you'd like to say something, I could talk to her for hours, as you can see, but that's not necessarily the point of this. So if you have comments, just throw up your hand or unmute yourself.
I probably should also just let everybody know that that we have now just republished the paperback edition, just came out about 3 weeks ago. And so there was a fair amount of rewriting in terms of the way ahead at that point.
Oh,
Because I really thought that mental disorders would come into law. And I guess that was a false aspiration, false hope on my part. But also because I really wanted to address the advanced requests issue. because I could see that that was now bubbling up to the surface. And in fact, Quebec has actually passed legislation allowing for advance requests in June of last year.
Oh, okay.
So what happens in Quebec will tend to fall into the federal government and legislation that will then kind of, spring its way across Canada. And it didn't happen before the House rose or this round. And I think it's all this, election prep. And the misfortune in all of that, of course, is that both of these issues now are kind of in the political domain, and not in the citizen repository of, what is a human right and what is autonomy and what is charter rights issues. So it's shifted its balance, and I hope it shifts back again sooner rather than later so that Canadians can actually speak to these issues.
Okay, Julie has a question.
First, I wanted to say thank you so much for your book, because there's been so much written in this area, but it's so disparate, and it's difficult to kind of bring it all together with some case studies and to get a deeper understanding. So thank you very much for that. I guess I have two questions. One is, is this being taught now in medical schools, or is it something that it's for physicians who are already out, or nurse practitioners who are already out in the community to then take the impetus to engage and participate?
It's certainly more in medical schools now, because the whole palliative care issue has now sprung to life. And it's interesting because I think we were really deficit in terms of palliative care. I mean, I know everybody understood it, and we certainly had palliative care units. It was very difficult, the interface between active medical care and palliative care in hospital settings. Even when I was kind of doing my year of independent learning, and I was up at Sunnybrook and going into the active oncology clinics that were up there, we did not present ourselves as palliative doctors. We presented ourselves as the symptom management team. Because you didn't bring the word palliative care into that. It just was not done, it was not done. And I think because once the legislation got introduced, the issue of was palliative care offered as part of your option of all of your end-of-life care, it became far more important to kind of be able to say to patients, have you had any talk with the team, your oncology team, or your cardiologist about palliative care? And so literally over the 7 years, the push has come. And because we now are kind of working much more with palliative units around, these are options, these are end-of-life options that must be on the table. So yes, Canadians know about it much more, but in fact, there is now much more permission, if you will, to sort of say end-of-life options include your option to have an assisted death if that is your choice. And as I say, not many people will ever take it. But for those who do, it's now and so people who say, I want an assisted death have almost invariably, like over 85% now, been offered palliative care. So that's a very big change. Yes. So is it in the domain of public information and what gets offered as part of a medical team's approach? Yeah, it's there now, and it wasn't before.
Yeah. And I guess if I can ask a second question, Sam?
Yeah.
It's about the right of refusal on behalf of a physician or a medical professional.
Mm-hmm.
Because this has now been proven as a charter right.
Mm-hmm.
We see a lot about vaccinations and the expectation of medical professionals around vaccinations, and other preventative efforts, and then there's so much written about abortion and the right of refusal for a doctor, and what are the conditions under which that can be done and what proofs need to be put in place. Mm-hmm. What about this issue? Do you see something as the growing such a we're living longer, and medical treatments are more advanced, and we have a huge aging population. Do you see this becoming a part of this right of refusal becoming more of an issue for patients and for medical practitioners?
I think this has gone as a test case in a number of provinces. And certainly the Canadian Medical Association has been very clear that you have the right to refuse, but you do not have the right to not do an effective, and I say this is the word, effective referral forward to somebody who can move the dialogue forward if you're not prepared to. So and you face censure now in terms of the colleges if you refuse to do that. So so I think it has become, and this is actually, they've certainly done this in terms of faith-based organizations now, and they've done it certainly in terms of sort of medical practitioners who basically say, this is my right. So they now face censure if they do not do an effective referral. So the reporting system is now much more robust, if I can use that word, in terms of making sure an effective referral has happened. It may not be done graciously, if I can say that, but I sure see that effective referrals are now much more in play than they were.
Thank you again.
You're welcome.
Thanks, Julie. Deb, do you have a question? I saw that you had unmuted yourself. You are still muted. Here, hang on. Let's try this.
Better now?
Yes, we've got you.
Okay, good. Okay, so as a person who is dealing with long-term pain, chronic pain, and the worry that I'm going to lose my mind as I get older, so I am concerned, like a few people that I have known have had dementia or Alzheimer's.
Mm-hmm.
So is it possible now to get that in place? That a doctor could help me leave before my body is, like if my mind is gone, but I have an order in place when I'm at a certain stage that I don't know anybody or myself anymore, that my family or my doctor could help me.
Yep, and if you live in Quebec, yes, but if you, yes, and in fact, so that legislation passed in Quebec in June of last year.
I did see that, just only in Quebec.
Only in Quebec.
So I
say,
have to move. Oh
no,
God.
they won't take you.
Happy.
They're very precious in Quebec.
Yeah, they
Boy,
are.
they're precious. Yeah, they are.
Okay.
So, and in fact, you see, I don't think the clinicians in Quebec were all that keen to rise up to this bait either. So there was a notification that went out from their Committee of the End of Life Care that is basically the foundation organization in Quebec, because they've always moved ahead of us. They were the first to put end of life legislation in place before the rest of Canada did. But they sent a notice to all their clinicians in the province saying, we've passed this law. You should refer to it so you understand it is now law. And we're going to give you guys until 2025 to make sure that you in fact are doing it, because you don't seem to be doing it too quickly. So so they have kind of served notice a little bit in Quebec that get with the program, get on the bus, guys. Mm-hmm. I kind of thought that since they did that it would just simply roll over, and that the federal government would do as they did for Couchon and Glado. It was the Quebec National Assembly that basically said this was a charter right issue. You could not stop people whose natural death wasn't reasonably foreseeable from requesting and having made. So, and basically they just rolled on with that one and said, this goes now across Canada. So if the expectation was that it happened in Quebec and therefore the rest of Canada would follow suit, that did not happen.
So is there any way to
it will happen.
advance that?
It will happen. As I always say, stay tuned. Um, but again, it is really the push from the population. And there's no doubt that the majority of Canadians want advance request legislation. Now, that's different than advance directive, okay? Advance directive is law, it's already in place. But an advance request that lets a physician end your life when you are not there to consent for that procedure, because you have lost your mind, and you don't know who you are, and you don't know where you're at, and you are being fed, and you're being diapered, and you're being turned, and you're being, that basically, has yet to come. Although certainly some of the clinicians in Canada, and I'm one of them, basically say if you have a diagnosis of Alzheimer's, you're on a trajectory to death. Your death is foreseeable in 6 to 8 years. That makes you eligible in my frame. But it's always a question of you're the one who sets the date. Most people who have that diagnosis aren't ready to proceed in the moment. They just want to know they've got the option. So what some of us do is we tend to follow those people very closely. And in order to be in a position to say, you're close to losing your capacity to understand this request and the consequences of your ask. So now you should set the date sooner rather than later. So that's how we operate now. And believe it or not, that's how we operated from the get-go. I mean, that's how I operated, but it will change. It's certainly, we use the model as what happens in Belgium and Holland. They have had this legislation in place. It's probably the most controversial, and it's probably the one that mostly ends up in the courts more than any other circumstance, when somebody basically is sort of put to death because of their Alzheimer's and because they're not present cognitively anymore.
Yeah. Okay, thank you. Thank you very much. I enjoyed your book.
Dr. Marmoreo, I can't help but thinking back to like the 90s and Dr. Kevorkian and the jokes, and it was such a news topic, and late night hosts were making fun, and there were all of these conversations. What do you think of him now?
Well, he went to jail.
Because it was against the law at the time.
It was a criminal act, yeah.
But if he existed today, when it was made legal, do you think he would have been a colleague?
Mm-hmm. Absolutely. Absolutely. I mean, I think he was providing a service, but it was a criminal act.
Mm-hmm.
So he was operating outside the law. If the law does anything, it gives people, practitioners and patients, like the boundaries and the duty of care. So I don't object. I was so pleased when it was able to become law, but I could not and would not have acted outside of the law beforehand.
I just think it's interesting when you look back on massive people who had those moments of, they called him Dr. Death and they called him all these things, but I mean, obviously not knowing him personally, but I'm assuming it was done out of an act of empathy for these people who were terminal in the case, but again, acting outside the parameters of the law at the time. It's just so interesting how history changes, and how now not only you don't have to be terminal, but we have all these other ways for people to die with dignity. When you think of the word dignity, and I will wrap it up after this because you've been so gracious with your time, and I could ask you questions for hours because I just think you're fascinating. But I want to end it on the word dignity, because I think dignity, dying with dignity is the most important part of MAID.
Yeah.
What does dignity mean to you?
I think it is about your sense of purpose pride in being, the sense of goals accomplished or life lived with values that you can actually carry to the end of your day. So people live wonderfully rich lives of purpose and value and productivity. And if things happen, disease or illness or disability or impending death from that matter, whether it's because you're losing your mind or because your organs are failing, I think people who have had a sense of independence and pride and worth and value carry that forward into sort of the process of dying in the way they did living. And it is also, I think, about finishing things that you started. And I think too often, because we don't talk about it and because we don't round up talking with people about the end of their lives, people are shy away from that. They see people who have lived wonderfully rich and productive lives, and they are afraid to talk about, and are you going to die richly and wonderfully as well? Nobody wants to go there, so you don't. Nor do you say to people, because you won't have that conversation about the end of their life, you won't say to them what they have meant to you. People have a lot of difficulty saying, if only I had known what I would have wanted to say. And I think the same with people when they know that they're selecting to end their life on their own terms in their own time. And then everyone comes to see them. You know, when I talk in the book, basically with Thor, he had everybody come. He had a big party, you know, to say goodbye to them. Not that they knew it. He knew it, but he wanted to be able to say goodbye to people who mattered to him the most. But you can see if it was that important to him to be able to look at them all and say goodbye, not that they knew it, how important it is for them to be able to look at him and say goodbye to you too, sir, because you've meant so much to me. So it is about ending your days by ending, you know, by fashioning that end that is full of pride and it is full of sharing and it is full of connection. I say one of the things that comes up over and over and over again, you know, when people say their last words to their family, it's always the theme is the same. The same thing comes out over and over again. Take care of each other. Look after each other. You know, pay attention to each other. I have raised you to care. I have raised you to be responsible human beings who are connected and who care. Those are the themes that I hear over and over again. But it's so important to be able to say that and to have it said back to you as well. That's my sense of dignity, is that people honor you as you honor them.
And now that you've made us all cry before we go home, Dr. Marmoreo, thank you so much for your time and for the book and for all that you've done for your patients. I know that it's probably not always been easy. I can actually probably say with certainty it hasn't always been easy, but you're doing a good thing for people. And I so appreciate the time that you've given to us tonight. And I will be following to see what you're doing and all of those good things.
Well, I'm so glad it happened. Even though you're kind of are kind of funny people out there, you know, you don't know about times, but you know, I'm very glad we were able to
Time
make
stands
it
still in
happen.
Saskatchewan, unfortunately. That's just the way things work here.
Okay, if only, my dear. If only.
Thank you so much. Have a lovely night.
Thank you. Okay, and to all of
Take
you,
care.
good night. Okay,
Good night.
bye-bye.